And with that, I want to ask Sheriff Rich Lucia from the Alameda County Sheriff's Office to come introduce Director Botticelli.
Okay, so disclaimer, I'm not actually the sheriff of Alameda County. I'm the under-sheriff of Alameda County. The sheriff's an elected official, and I'm glad that he is. So for those of you who are standing back there, I understand why, because after sitting in these chairs all morning, you would rather stand than sit. I got that. In Alameda County, we're fortunate to have a lot of very concerned people who are working in a lot of our public agencies, certainly not just the sheriff's office. I want to just take a second to say that we are not there yet, that we don't have the answer yet on enrolling inmates, but it's certainly something that we are going to do. I can guarantee you that. So as someone responsible for public safety in a county with unique challenges, it's exciting for me to be a part of a conversation that puts not only prevention, but treatment of substance use disorders for the jail involved at the forefront. About 18 months ago, a Berkeley law graduate who was working toward a PhD in jurisprudence in social policy contacted Cochs saying he wanted to do his dissertation on the impact of the ACA on justice-involved individuals. But Cochs told him that it was too soon for impact, but he started volunteering at their office. As you heard just a few moments ago, Cochs has been working with California Forward and Californians for Safety and Justice to develop these cross-silo cutting convenings, and we had one of those in Alameda County. And once we involved ourselves in that, the Sheriff's Office asked, how could we involve everyone leaving our jail? And we are determined to do that. Working with Cochs, we're exploring how to take advantage of the 2012 CMS regulations that allows correctional facilities to be the authorized representatives for purposes of enrollment, and how to use booking data as a vehicle for enrollment. You've heard some of the problems that are associated with data and cross data and verifying the people who need the service the most. I'm also pleased to report that the Alameda County Sheriff's Office has since invited Dan Mistek. Dan, can you stand, please? There you are, Dan. To do his dissertation research on what ACA means to our work in the Sheriff's Office. And in cooperation with Health Affairs, there are 3 late-breaking blogs that supplement the articles. One of them is by Dan and his colleague Jonathan Simon that describes UC University and the Sheriff's Office collaboration in greater detail. And I'd like to encourage all of you to consider developing similar relationships that will allow us to research the impact of the ACA in real time. There are 2 other blogs, one by Nancy Dubler. Is Nancy here today? Yes, Nancy's over here, thank you. On the ethics of healthcare in jails. And one by Michelle Martell. Michelle, she's sitting in the back, but not standing in the back. I got that. On the experience of implementing the ACA at Rikers Island. So lunch will be a great opportunity to network, and I would encourage all of you to use this opportunity to network with the bloggers and the panelists. So if you all didn't see who they were, maybe at the end of the session you can run into them, I hope. Now my reason for being here is to introduce Michael Botticelli, who is the Acting Director of the White House Office of National Drug Control Policy and has over over 2 decades of experience supporting Americans affected by substance use disorders. He's aware of the significant commitment and effort that is required of jurisdictions at all levels, from policymakers to management, line staff, to make effective, coordinated substance use treatment a reality for the jail involved. We in the Sheriff's Office are looking forward to working collaboratively across our silos with healthcare and social service administrators and staff to achieve Director Botticelli's and the White House's vision in Alameda County. Please join me in welcoming Michael Botticelli to the podium today.
Thank you, Undersheriff, and I'm the acting director, and I'm understanding that there's a vast distinction between director and acting director, but it really gives me great pleasure to be here today among so many friends who I've had the opportunity to work with for a very long time. You know, and I was sitting here thinking that, you know, it doesn't escape my notice that about 27 years ago I was in handcuffs. And I'm standing here as the acting director of the White House Office of National Drug Control Policy. And it's wild. But I think it's a testament to all of the work that a lot of people who came before me have set. And I was talking to Cynthia Caparizzo while the other panelists were speaking, and I was like, God, we have a lot of work to do. But it's really a pleasure for me to be here, and thank you, Undersheriff, for that introduction. Not only is the ACA making healthcare a reality for many people, it is transforming drug policy in the United States. It's changing how we address substance use disorders and helping make criminal justice reform and alternatives to incarceration that offer substance use services a reality. I'd like to thank Steve Rosenberg. I had the pleasure of being involved with Cochs during the time that I was in Massachusetts, and they were some of the most vibrant and energetic discussions that I think I've ever been involved in, and I really thank you for your leadership on that, and particularly keeping the spotlight on healthcare reform and its intersection with the criminal justice system. I'd also like to recognize Health Affairs for sponsoring this conference and for publishing such important articles on jails and the Affordable Care Act in its March issue. And thanks as well to the Robert Wood Johnson Foundation, the Langlaw Foundation, and the Public Welfare Foundation for their support. And I also want to recognize all of you who are here today for your incredibly important leadership at this critical time for our nation's health and for criminal justice policy. When the Office of National Drug Control Policy released this administration's first national drug control strategy in 2010, we established a new blueprint for reducing substance use and its consequences in America. The blueprint was based on input from public health and public safety professionals across the country and decades of research demonstrating that addiction is a disease, one that can be prevented and treated, and from which one can recover. The strategy was written with the knowledge that substance use disorders endanger the safety and health of millions of Americans, and that our country was in need of a new direction in drug policy, one grounded in common sense, scientific evidence, proven results, and most of all, compassion. The administration is implementing an approach that is progressive, innovative, and based on research, and we have fundamentally redefined the way we perceive and respond to substance use. Expanding real evidence-based drug policy is a huge undertaking and not always easy, and one that relies specifically on the work that you do every day. Having spent most of my time addressing public health issues at the state level, I have a special appreciation for the work that you do. The Affordable Care Act is the most significant piece of drug policy reform in generations. By expanding insurance coverage, it expands access to and parity for substance use disorders for an estimated 62 million Americans. Treatment should not be a privilege limited to those who can afford it, but a service available to those who need it when they need it. Prior to coming to ONDCP, I served as the director of the Bureau of Substance Use Services at the Massachusetts Department of Public Health. And our experience with healthcare reform showed us the potential for expanding access for those people who never had regular or consistent care for any condition. In the beginning, we found that despite coverage for substance use treatment, many individuals with substance use disorders, particularly those justice-involved populations, remain uninsured. It was clear that they needed assistance in getting insurance and accessing care. And coverage was not enough. Justice-involved individuals needed supportive services to attain and remain in recovery. In addition to treatment, it takes housing, employment, something as simple as even helping them get a valid identification so they could sign up for care. If the Massachusetts bears out nationally, and I would assume that it does because I'm from Massachusetts, the expansion of healthcare is a huge first step, but facilitating linkages and providing comprehensive support are critically important. Of the 23.1 million Americans who need treatment for a substance use disorder in 2012, only 2.5 million actually receive the treatment they need at a specialty facility. This is absolutely unacceptable. The Affordable Care Act is the best tool we have to ensure that people get the substance use disorder treatment they need by requiring insurance companies to cover treatment for this disease just as they would any other chronic condition. The ACA extends the reach of parity requirements by making mental health and substance use disorder treatment one of the 10 essential benefits health insurers are required to cover. There is also the potential to expand recovery support services offered by the community organizations. These services can help prevent relapse, can help people bounce back if they do relapse, and can offer the supportive services people with substance use disorders need for long-term recovery. In this arena, leadership not only includes ensuring that insurance benefits are comprehensive and address the full spectrum of substance use disorder treatment. I have to say this, Steve, grade A sausage. People who write Cochs will know what we're talking about, including prevention, early intervention, and recovery support. They also include working to make sure that people transitioning from the justice system to the community are enrolled in healthcare coverage. 7 million people have already enrolled through healthcare.gov, and millions of more through Medicaid expansion. Of the more than 40 million currently uninsured Americans, the majority were able to find a plan for $100 a month or less in 2014 under Medicaid expansion. As leaders in justice, corrections, and healthcare, you have an important role in helping people access affordable healthcare in your states and communities. We must also embrace effective, appropriate, evidence-based treatment mechanisms. Like all chronic diseases, substance use disorders can be effectively treated over the long term, particularly with the help of medications. Behavioral therapies play an important role in supporting recovery, but individuals with opiate use disorders do best when given medication-assisted treatment, just as someone with diabetes or heart disease. The Food and Drug Administration has approved 3 medications for the use of the treatment of opioid disorders: methadone, naltrexone, and buprenorphine, as well as several for alcohol use disorders. We also encourage primary and specialty care providers treating justice-involved populations to provide these medications as a part of a comprehensive approach to treating opioid use disorders, including those involving prescription drug. Regardless of whether a person is incarcerated under community supervision or reentering the community, he or she should not be denied a viable and evidence-based medication to support long-term recovery. For example, jail health services can provide medication for those in custody and develop an opioid replacement therapy program that connects newly released individuals with community-based clinics for follow-up care. And I'm looking at my good friend Jody Rich, who really did a lot of this work early on in Rhode Island. Treating opioid use disorders with every tool at our disposal helps us address another growing public health issue: overdoses. The Obama administration has been working for years to address the epidemic of prescription drug use using education, monitoring, disposal, and enforcement to abate the availability of non-prescribed medications and reduce the incidence of addiction to these legal substances. At the federal level, we have developed resources for prescribers. My office worked with the National Institute on Drug Abuse and SAMHSA to develop 2 free online training tools for safe prescribing for pain and managing pain patients who abuse prescription opioids. These courses provide healthcare professionals the critical skills to manage high-risk patients and more safely prescribe prescription drugs. These are all steps in the right direction, but we are losing far too many people. In 2010, we had an average of 100 people die every day from a drug overdose. I have a hard time saying those numbers without being tremendously moved by the level of mortality that we are experiencing. Unfortunately, recent data also indicate an uptick in the use of heroin, another opioid involved in a significant number of overdoses. We must focus also on preventing overdose deaths. As we have done in identifying the warning signs of a stroke or heart attack, we can help save lives by recognizing the signs and symptoms of an overdose. Education is the first step, but we are also promoting the use of the opioid overdose reversal drug naloxone among people who are likely to encounter overdose victims, such as family members and first responders. ONDCP has partnered with law enforcement organizations across this country to promote expanded naloxone access to training on overdose prevention. Naloxone is a medicine that can rapidly reverse an overdose caused by opioids. Where states have equipped police officers and other first responders with naloxone, the outcomes have been nothing short of miraculous. The police department in Quincy, Massachusetts, which is a small town south of Boston of 60,000 residents, has partnered with the state's health department to train and equip police officers to resuscitate overdose victims using naloxone. Since October 2010, officers in Quincy have administered naloxone in more than 220 overdose events, almost all of them resulting in a successful overdose reversal. Overdose prevention information and naloxone kits can be included as part of a reentry process. In Massachusetts, the overdose prevention plan included education for those at high risk of overdosing and linked them to community services upon release. The San Francisco County Jail Health HIV and Integrated Services Program provides training on how to use naloxone in the event of an overdose, and it offers naloxone kits to individuals upon release from custody. We cannot discuss substance use disorders in this setting without acknowledging the prevalence of addiction in criminal justice system, the lack of treatment, and the risk of severe consequences. If the administration's drug policy is built on the scientific foundation that a substance use disorder is a disease, any successful criminal justice reform program must address substance use disorders as a root cause in the cycle of drug use, arrest, and incarceration. Among men on probation and parole, untreated substance use disorders pose a significant problem. More than 40% of probationers and more than 38% of parolees have substance use disorders, but less than 20% of each group receive treatment in a specialty facility. Further, the justice system is the second leading referral point to treatment for substance use disorders. The Affordable Care Act is important in the expansion and success of effective diversion programs, and it also plays a key role in helping people stay out of the criminal justice system in the first place. I have talked about the ACA in regard to treatment, but it's critically important for prevention and early intervention as well. It is not difficult to see if untreated substance use disorders play a part in getting someone involved in the system in the first place, that prevention and early intervention can play a role in keeping someone out. Preventive care services is part of primary care services. If we see the warning signs, if we intervene before the illness or condition worsens, if we remain engaged in a person's prevention regimen, as we do for other conditions, preventive measures for addiction may help someone from getting tangled up in the criminal justice system. We all know individuals with a substance use disorder should be treated by the healthcare system, not the criminal justice system. But for those who are already in the system, criminal justice reforms efforts supported by the ACA must be implemented. Particularly important are reforms to sentencing and charging at the state and federal levels. And I know that you heard from Tony West early today in terms of the Attorney General efforts around these areas. These changes help reduce our dependence on jails and prisons as a way to deal with people with substance use disorders. Under the Attorney General Holder's leadership, the administration is taking significant steps to divert low-level, nonviolent offenders into services and community probation instead of federal prison. Reserving the harshest penalties for the most serious drug offenders can also help reduce the inequality in our criminal justice system and avoid locking people up for crimes related to their substance use disorders. Many states, and many of you here, are engaged in the Justice Reinvestment Initiative and are examining their sentencing and corrections models and using data to make decisions about legislative reforms that will help reduce the number of people behind bars while still maintaining the safety of our communities. We need to reduce the prison population and break the cycle of drug use, arrest, and incarceration, and connect nonviolent drug offenders to sentences and sanctions that employ evidence-based treatment rather than incarceration alone. Drug courts, pretrial diversion programs, and smart supervision programs like Project Hope that use drug testing, sanctions, and supervision to protect public safety while holding people accountable for their criminal acts and giving them the added incentive, the possibility of jail time, to adhere to their substance use treatment plan. The most effective approach is to develop a full continuum of interventions that include appropriate supervision and supervision at every stage of the criminal justice system. This means connecting people with treatment services that match their needs while they remain in the community. ONDCP is funding an initiative to develop such a model for practitioners. The National Association of Drug Court Professionals is leading this project and is working with national criminal justice experts and other organizations on the model development, training, and technical assistance. And we hope this model will enable jurisdictions to allocate resources for programs and strategies that reduce recidivism. Rethinking drug policy is a complicated task, as I am quickly learning. Much of the work is done at the state and federal levels. So I'm glad to have the opportunity to share our federal perspective. Moving forward, I hope that all of you will continue your leadership in establishing a more comprehensive system of care for people with substance use disorders, advocate for the availability of life-saving measures, and support people re-entering their communities from a period of incarceration. Once again, I would like to thank Cochs for keeping the spotlight on such a critical issue for justice-involved populations. I look forward to continuing this conversation and for continuing this work and working with all of you to make our country safer, healthier, and more just. Thank you. We have time? Yeah.
So Mike's going to take questions. I have to just go back to Mike's joke about Class A sausage. So as Mike mentioned, Cochs convened, I guess it was in 2009, if I remember correctly, in 2010, with Allison Hamblin and Steve Summers and Center for Healthcare Strategies, some working groups where we brought together single state agency directors and state Medicaid directors to sort of try to define how do we cross over these silos. And we kept running into this ongoing joke that we needed to figure out what the quality metrics were that were in order to do this, and we ended up calling it grade A sausage. So I appreciate that. And with that, questions for you, Mike.
Let me make one comment, because I was really interested in folks that were talking about kind of developing metrics, and Paul's question about, particularly in New York State, how do we really look at the impact of ACA, particularly as it relates to, and I will tell you, it's not easy work. And, kind of my goal in Massachusetts was, I have to say, I failed miserably at when I was leaving, was to create this client-centric data warehouse with Medicaid data, state single agency data, as well as criminal justice data to be able to really tell the story. I think, one of the things that I think holds great promise that many states are implementing what's called all-payer databases, which I think is particularly important for, as state agencies are less going to be the holders of who gets treatment, particularly by insurance companies. All-payer databases, I think, will play a key role in terms of looking at the number of people who get treatment from various payer sources, and being able to link that to obviously criminal justice data becomes really important. But it's hard, so no disrespect to lawyers in the room, but I felt like if we left the lawyers outside for a later date, that we usually got a lot farther than we did by having them in the room at the first place. I joking aside, obviously we had to worry about confidentiality and HIPAA issues, but it's a challenging task. But I think a really, really important task that if we really want to make the case for not only this population, but for continuing resources, it's really crucial.
So this is all very exciting. I'm David Dvorny with the Office of the Assistant Secretary for Planning and Evaluation at HHS, and there's so much happening, and just the opportunities are huge to especially provide, I think, services on the substance use side that haven't been available in the past. But the workforce challenges, I think, are going to be huge, and I wondered if you could speak a little bit to the efforts to try and build the provider capacity out there to meet some of these opportunities.
Sure. To the extent that I can, it's it really is a huge challenge, I think, in terms of having a prepared behavioral health workforce, and I think that there are many efforts. Some of the work that I think that's been happening through the Vice President's office and the Now is the Time initiative, in terms of looking at putting out additional dollars for the enhanced efforts around training, having a trained-up behavioral health workforce, I think are going to be particularly important. But I think it really requires not only a federal effort, but also efforts at the state level, efforts efforts at the provider association level. During my time in Massachusetts, I thought that provider associations also could play a key role in terms of looking at how do we continue to have a prepared workforce. But I think it's going to be a continuing challenge as we move forward.
As we're focusing a lot on insurance and parity and also the Affordable Care Act and all the revenue streams for substance abuse prevention and treatment, we just are grateful that the administration gave us a really good request for the SAPT block grant, and it's important to maintain that funding stream for the services that states and counties provide that wrap around folks that need the support and that wouldn't be otherwise available through insurance.
I feel like that's a softball. That's the setup.
Just a thank you.
For people who've heard me talk about this before. So, our experience in Massachusetts, I think, showed us a number of things. And one of the most telling things was, as healthcare reform took place, we had about less than 2% of the non-elderly adult population who were uninsured, which is huge. And so, like any good state administrator, I was waiting, for the huge effect that we were going to see within our treatment programs and have all of these additional dollars to be able to redeploy in other areas. And don't forget, the starting point for Massachusetts was we had a really low uninsured rate to begin with. We had a really good state appropriation. We had a really good Medicaid program. So, our threshold was low. But one of the things that we found moving forward is that we saw about 20% of people who were coming to our treatment programs were uninsured. And I think if you look at the work of the Blue Cross Blue Shield Foundation in Massachusetts, they will substantiate that a number of particularly vulnerable populations are likely to show high levels of uninsurance compared to the rest of the adult population. And we actually did some subsequent analysis and found that the majority of those were young adults who were referrals from the criminal justice system. So it showed us kind of the need to ensure that we had other safety net programs that, one, continue to support treatment services for those who remain uninsured when coming to treatment programs, and two, provide the full continuum of services that were not going to be reimbursed by those by insurance companies. And again, I think one of the things that we saw was again that a lot of our incarcerated population didn't even have valid state IDs to be able to enroll in insurance. So we used some grant money to help support getting them identification to be able to do that. Clearly, things like housing and unemployment and vocational support were all things that were not necessarily reimbursed and were particularly important not just for this population, but for the vast majority of people who are coming into treatment who didn't have stable employment and who didn't have stable housing. So what we've been trying to do, clearly, and I think we were very grateful for the President's 2015 budget that actually did not include any decrease to the substance abuse prevention treatment block grant. I think going forward, I think it's going to be important for us to document the need, why we still need those safety net funds beyond 2015, and I'm probably saying more than I should, but I think it's going to be important for people to really show kind of why we continue to need safety net funding. And this crosses not just the SAPT block grant. I mean, this relates to Ryan White, maternal and child health. So, we heard before that many of our folks, particularly for our criminal justice involved populations, have multiple chronic conditions. So I think we want to make sure, and we need to, while insurance is huge in terms of providing folks, that we need to make sure that they're also getting the rest of the supportive services that they need that are probably not likely to be reimbursed by insurance. One time for one more.
Less of a question than a comment back to the topic of how we're going to make sure that we're getting the metrics from this and knowing and being able to track outcomes. In Vermont, we have been working with our Medicaid Management Information System and the folks who keep those, that data to, in fact, take on our inmates in the claims processing system so that they will be uploaded into the system and tracked as Z9 when they go out to hospital. That's how we track them now in terms of Medicaid payment. And we will then be able to know who they are once they leave the system, and also use that as a means of suspending rather than terminating eligibility as well.
Good, good. You know what, Steve, I'm thinking one of the things that we might want to do going forward is, particularly around training and technical assistance, not just of some of the mechanics of working, but really looking at states that have been able to do this. Kind of, you know, this kind of linked data warehouse as models or templates for other states to embrace.
Absolutely. And I think that we've been very blessed to be working very closely with Dr. D in Vermont and understand that in that kind of small state, as in Delaware, we're going tomorrow to Wilmington, where we're doing a smaller version of this for the folks in Delaware. To also go ahead in those kinds of small states to really be able to embed the data that Dr. D just described, which also answers some of your questions. How do we measure? Michael, I have to thank you. It's always a joy. It is a personal as well as professional joy. With that, it is time for lunch. Please remember to wear your name tags. You go down the stairs, you go to the left to the Thunder Grill restaurant, you go upstairs. Lunch will be family style. I want to encourage you to use this as an opportunity for networking. One of the things that we are blessed with is having all of you in this room with your different silos. We want to encourage you to take advantage of that. Thank you very much.